Very good morning to one and all. Welcome to this very interesting course. Now, with the plethora of investigative technology, with the plethora of the different IOL options that we have, it's almost become so confusing as to which patient to choose for which IOL and who is the most ideal candidate for each of these newer technologies. So this course aims to demystify many of these things as to how we use our pre-operative workup, our diagnostic techniques, what are the ideal candidates for particular IOLs, and if things don't go as per our expectations, how do we manage or how do we tackle these unhappy patients as well. So at the outset, I'd like to invite our first speaker, Dr. Samresh Srivastav, who's a very prolific cataract and refractive surgeon in Raghudeep Eye Hospital, Jaipur, and he'll be talking to us about the plethora of advanced diagnostics that we all have access to now. Over to you.
Thanks, Shel. Again, very good morning to everyone. I'll be discussing, on our strategy towards how to plan a particular lens for a patient in terms of diagnostics, because there is a huge number of diagnostics available in today's date and time. So, what is the bare minimum, and what is even better to have, and what is an indulgence? We'll try to break it up to get some overview. The first thing to understand is that you, at today's date and time, in this modern practice with this competitive environment, you do need a special workup. It cannot be a patient walking into the clinic and you just do a biometry and then do an eye cataract surgery, because the outcomes will be suboptimal because you haven't looked at the patient profile in toto. So you need a proper workup, but how do you go about it? And the real question is, will investment on all these machines, and more importantly, time and manpower, yield anything, any fruit at the end of all this? The way we do it at Raghudeep is we have a very dedicated team for a pre-operative workup, which essentially includes our optometrist who's going to do all the tests, technicians, and most importantly, a counselor who's available at that point in time to sit and discuss and address out and iron out all queries. But also we have a dedicated time slot. So if your clinic is running busy, you know that your clinic is piling up, and in the middle of it, if you have to do a pre-op, you'll rush up. नहीं नहीं आप तो कोई भी लेंस करा लो, ठीक हो जाएगा. But if you have a set dedicated time slot, particularly at the lean time of the day, which for us is mostly the afternoons or early in the mornings, then that time you can give time to the patient, because you know you are free, you can give chair time to the patient, and the team is tuned to discussing things with them. Also important to evaluate both eyes for whatever parameters you're doing. Both eyes should be evaluated in the same sitting, not just the eye that is going ahead with the surgery. So again, this is classically our trades. It's extremely confusing. But I think the one thing that we always stress upon, apart from, we all know that we need biometers, we all know we need keratometer, but what we actually need is to have a happy post-op patient. For that, we need to start with the lids, we need to start with the ocular surface health. So a good examination on a slit lamp is, I think, imperative, and for many times even I miss out on these things, but it's always a good habit to practice this out. But importantly, how is it relevant to us as cataract surgeons? Forget about LASIK. How is it relevant to us as cataract surgeons? Apart from potential theoretical concerns of delayed wound healing and infection, rehabilitation is a big issue in dry eye patients. But the biggest concern is an unreliable biometry, because when you have dry eye, or when you have a patient in the clinic and you've instilled these drops for dilatation and anesthesia, the ocular surface goes for a toss. And if then the patient goes for a biometry, you're going to get wrong readings, which will translate into wrong IOL powers, because the tear film is the first and the most important refractive surface of the eye. The light is not going to hit your cornea, it's going to hit your tear film. So this is how it is. An irregular tear film will give you higher order aberrations. Like you notice over here, there's a huge astigmatism and a lot of chatter. And in one go, we are able to say, no, this patient is not suitable for a multifocal lens. But that's not true. The moment you put a drop of lubrication, settle down the tear film for half an hour, everything will disappear, because if you notice in the previous one, Myers were irregular. So it's very important to not only get these tests done if you have them in the clinic, but also look at the photo, because you will make out that the optometrist has done a wrong job. And this is before and this is after. But how does it translate? This was before. So if you had to put on, say, monofocal lens, 21 diopters, after settling down, the biometry jumped from 21 to 20. So it was a 1 diopter surprise. And if that had happened post-operatively and we had operated with this biometry and ended up with a 1 diopter surprise, imagine the embarrassment, for us. And for a simple fault that we did not take care of the dry eyes. It's also important, good to incorporate tools. We know there are different types of dry eyes. Looking at our patients, mostly it's the evaporative dry eye. because aqueous deficiency dry eye will come to us with predominantly dry eye symptoms, not these cataract patients. So this is just to show you, this is a 22-year-old patient who came to me for a LASIK workup, and look how all the meibomian glands are completely missed, they're completely gone out from his eye. So we put him on doxy for a long course, but these are the kind of patients you want to be very clear about. So I've deferred refractive surgery for this patient because we put dry eye as a workup. Now you don't need a meibography, but you need to look at dry eye. But you can look out for these things when you buy topography machines, because when you go to the trade, they will tell you that our topo gives better K readings and all. But actually, topographies do also have lipid layer analysis, so it's a good idea. When it comes to topographies, posterior corneal curvatures are very important now because, especially for refractive surgery practices, because they take both the posterior cornea, just like, most of these Scheimpflug images, and we are moving from Scheimpflug to OCT based imaging. But posterior cornea for many, many years or for decades was not known or was not taken care of. And it picks up outliers, and it can flag out patients who are irregular corneas. And these patients are not suitable for multifocal lenses or freedom lenses like enhanced range of vision lead-off lenses. There have been papers that have been published that saying that you should calculate toric IOLs based on anterior and posterior curvatures, because anterior and posterior do not normally follow the rule. Anterior is generally with the rule in younger ones, and the posterior is against the rule, so it tends to cancel out. But the good news is that for most of us who are not so fastidious, most of these newer generation formulas take care of posterior corneal curvature. So you really don't have to look at it. The new biometers will incorporate it. I'll just move on to this. So it's important to at least know about it and use newer generation formulas for this. Specular, I cannot emphasize on more, because if you have extra, if there's a diagnostic you want to add, both for cataract and refractive, you need a specular, because the specular is going to give you a lot of details. But if you don't have a specular, treat every patient like it's a low endothelium count, and be careful of giving energy and using dispersive viscoelastics. But this is a good tool to add, because it can pick up outliers like this, who, the crystal clear cornea. If I didn't have a specular, I probably would have missed out these findings, because they're generally not visible. Biometry, time to move on from contact to immersion and on to optical, and then to swept source OCT. Optical biometry, I think, is now becoming easily accessible, and it's become cheaper over the years as a technology, so one can acquire it. Most importantly, because it measures your visual axis or your point of fixation rather than doing a touch or having a broad source of light. So optical biometries are always better, because the axial lens are on the manifest visual axis. Swept source OCT is an even better tool, and there are many companies that are now coming off with it. We did compare biometric parameters using two different principles, using a lens star and using a swept source OCT. One is an optical, the other one is a swept source. The only good thing about swept source is we were able to get penetration better. So we had 10% more penetrations than an optical biometry. But in terms of reliability, both were equally reliable when we did capture. When we look at formulas, I think our go-to formula is the Barrett formula, which is now, as most of you would know, or if you haven't used it, it's available for free at the APSCRS website, thanks to Dr. Graham Barrett. And it's extremely predictable, and you're generally, for us, we don't really have to break our heads with this. Our team also published calculation based on the post-refractive surgery eyes, where we did not have prior refractive data. And we did find this to be a reliable formula as well. The True K is a post-refractive surgery formula from Barrett, Dr. Barrett again. So the Barrett Universal 2 is for virgin eyes, the Barrett True K is for post-refractive surgery eyes, myopia, hyperopia, or RK done eyes. The PRK done eyes, it would do well. Again, when you look at biometers, like this is a lens star, but new biometers, they do have a toric calculator embedded into it. So you don't have to waste your time to go and sit down at a computer, feed in the data, or call up the company technician, please help me calculate my toric lens. If you have an optical biometer which has a formula in it, you will get it in the printout. So you don't have to really mind your head. You just look at this formula and you can counsel the patient that the patient needs a toric IOL, because it's very much in your face. So if you negotiate machines, please look at the formulas and just don't look at the pricing point of view. Aberrometry is an indulgence. It's not necessarily the primary tool that you do need. I'm just going to show you how aberrometers, and you'll be hearing more of a lot of these in every session now. They deconstruct the eye, because your eye as an optical system is cornea, its lens, and its retina. So you have total eye, which is your entire eye's irregularities, and because you have a topography attached to the machine, cornea, and subtract the cornea from total eye, you get, very interestingly, a very good number called an internal aberration of the eye, which essentially means your cataract or your lens and how it's behaving inside the eye. A cataractous lens or an IOL. So this will help you in telling you if the patient is happy or not. Important to document with topographies. All your tests, including your autorefractors and topographies and aberrometry, should be done in a dark room, mesopic room, because that's the challenge. Because patients will come to you complaining, saying, "Raat ko nahi dikhta hai." Daytime, most of these people will not have problems because pupil dilates and it becomes irregular. So it's good to document everything in dim lighting conditions. I'll just jump out of this to to more important. Just to give you an example, young patient, sticky because lawyer, 6/6 vision and can't drive at night. So it's not uncommon. We've seen these patients. They come to our clinic. Lens looks relatively clear. Just some vacuoles for a 47-year-old. But look at the aberrometric data. So we do have, like I said, we do aberrometries in dark rooms. So it's a 5 mm pupil. There's a huge spherical aberration coming from inside the eye. So this is internal optics. Spherical aberration is essentially refractive index change. So what could it be? It has to be the lens, which is sclerosing before it's visible clinically. And that's the problem. You look at it on slit lamp, patient is fine. But you actually look at it there, this is what the patient is seeing in dim light. And this is how we are checking the patient in 6x6 in bright light, our LED screens with full lit room, our refraction rooms. So it's all, we are misjudging these patients. If you do a dim light refraction, that's how the patient is. Can't reach 660. But in bright light can reach 6.6. Pentacam or your right rays and all will show that there is a sclerosis happening, which is not turning yellow. So it's difficult to make out on a slit lamp evaluation. So we do a cataract surgery for these patients. Another patient, straightforward astigmatism. We said, let's do toric IOL. Patient is refusing to believe that they has a cylinder because the patient's never worn a cylinder. She's worn glasses the whole life, never worn a cylinder. Now this is how aberrometry comes to use, but you don't really need aberrometry for this. I'll tell you how. There is a manifest refraction, shows no cylinder. 0.37 is the astigmatism. So the total eye is also no cylinder. There's a very nice corneal cylinder which is nearly completely cancelled by the internal optics. So the lens has a cylindrical value which is exactly opposite of the corneal cylindrical value. Now what would happen if you do a cataract? You're going to knock out this cylindrical value because you remove this lens. And once you remove this lens, all the cornea will manifest. It's very difficult to explain to the patient, but if you have something like this and you can objectively show that this is what is happening, boss, once you remove this, you will need to wear this cylindrical correction because your keratometry shows 1 diopter of astigmatism, and at that point the patient will understand and it will become easy for us to counsel that this patient does need a toric lens and it can be balanced. And once you put a toric lens, you can check the toric lens with these machines. So this is an astigmatism, another patient, astigmatism and a toric lens. And look at the post-op refraction. It's like less than a quarter on sphere and about a quarter diopter on cylinder. And that's a good outcome. So this could be a happy patient, but you could also put a bad patient and then see what is happening in this eye. And you'll have a very clear understanding of what's happening. So like I said, indulgence, because unhappy patients are far and few. But when they're there, rather than shunning these off, it's best to at least get these tests done because you will know what the culprit is and you will be able to target in giving a treatment approach. Sometimes, it's very, very interesting. Now this machine, the new aberrometers can also span out your depth of focus or what is your range of vision, even for pseudo fakes, but also for phakic patients. So if you're planning refractive surgeries, you can see what is the depth of accommodations. Last but not the least, retinal evaluation. I think this is not an indulgence anymore. I think it's preferably required if your practice can support it, is not only to do a dilated evaluation. We've actually started imaging all retinas now. So we have a dedicated SLO which does captures for all retina as a part of the OPD workup, not even a pre-op workup. But the more important thing is to do retinal OCT, because what your eye can't see, the OCT will pick up. So Aditya from our team published this on, we did a study which was an observational series on at least one of the patient that was undergoing cataract surgery, no retinal comorbidities. Retina doctor had seen these eyes, labeled them as normal, and the retina doctor was masked to the OCT finding. Okay, and what did we find in these 200, close to 200 eyes? We found with the senile cataract and no other comorbidity, all plethora of diseases, starting from epiretinal membranes to VMTs to parafoveal telangiectasias, situations that you would not pick up with the naked eye, especially under a cataract, because it's very difficult to see. Also in a busy practice, who's going to sit with that 90D and scan all the time when there's no problem? So an apparently normal looking retina with an ERM. Now this is not a patient you want to put a trifocal lens in, because this is clearly, this patient is going to have a low contrast scenario. You have a lamellar macular hole, which sometimes it's easy to miss out these lamellar macular holes. RP irregularities, small foveal burns, vitreomacular tractions. These are the things you will miss out. And once we miss out these things and these patients, we put these really nice, good optic lenses, and the patients are unhappy, unnecessarily the lens gets the blame or the surgery gets the blame when neither is a problem. Problem is the patient's eye. So you can show these to the patient that this is your problem, this is your eye, and that's the limitation of your eye, and they are quite accepting to these issues. Uh, Again, just to summarize it all, it's a combination. You need to understand the science. In our clinic, we like to evaluate everything from the corneal epithelium all the way to the retina to the choroid, because we did the entire mapping of the eye, and we want to counsel the patients all the negatives first, and more importantly, because once they've listened to it, they will accept it better. But the most important thing is not only to do these tests, but to sit down and show all these tests to the patient, because once it makes sense to them, they will absorb whatever you give them. That's the epitome of personalized care, and I think we are all, as colleagues, we should all aim for the best through there. Thank you.
Thank you, Dr. Samresh, for that very nice, elaborative, exhaustive talk across all diagnostics. If there's someone who has to decide and pick and choose, what would be your two top, diagnostic equipments in today's time, which you feel should be a part? I mean, that's
So
something
I
that
think
you.
I think at the least, if I were to set up a new clinic, I'd put an optical biometer and I'll put up an OCT. At least because I know my calculation is right. I can do a dry eye workup on a slit lamp and non-invasive breakup time and all that, but I can't replace a good biometry, and I can't replace that OCT, because I think OCT is right now extremely important, because there are so many outliers and patients are quick to judge. First post-op they want 6 by 6. So for me that would work.
I think that's excellent suggestion. That getting a good calculation, your surgery is improved, but your surgery is judged by your refractive outcome and not just how good you operated inside the eye. And the post-operative outcome, particularly with these many newer IOLs, I think OCT is of paramount importance. Thank you so much, Dr. Samresh. It's my pleasure to invite Dr. Ajay Sharma, who will be talking to us about a holistic approach to choose which IOL for which patients. And as most of us know, he is the founder and the director of IQ chain of hospitals.
Good morning, everyone. Thank you. We have talked about the diagnostics in our cataract surgery, and next very important thing is the lenses what we choose. So nowadays the requirement of the patients are entirely different. They demand new technologies, and we have a lot of them. So we have to decide the lens as per the visual requirement of the patient. So just to show how you have to see whether patient wants to do a near thing, distant, or including intermediates. We'll see case wise. So these are the lenses which are available. Ideally, a lens should be has a spheric surface. It has a polymer material, low refractive index, and not a material which is not associated with glistening. Then it should be UV blocking and hydrophilic acrylic material, which we all know, hydrophobic acrylic, which we all want to use. So these are the modern lenses which are available. We say in the pseudophakic, we have a monofocal and the bifocal lenses or the multifocal lenses. There's a new thing which has come up is the monofocal plus lens. Multifocal can go with the diffractive, refractive, and the other can be extended range of vision, and then it can be accommodative IOLs also, which are no more used most of the time here. So normally we'll see these how we use these bifocal, trifocals, and all. So before a word of intermediate vision, very important, because we need to see what a patient want. Because intermediate vision can be different for different people. Intermediate can be using a tablet or a computer, can be around 40 centimeters, and shaving or styling hair can be around 80 centimeter, and it can be cooking, checking price tag, and computer work for various other peoples which we look. So this again is very important part. So we do the counseling, and we ask the patient to choose a technology, whether it is a conventional or a femto, and the lenses again monofocal, multifocal, or extended or trifocal lenses, or the CRV lenses. Now, monofocals are most widely used. We all know about that. So we can use in all the patients. Definitely choosing the right lens, which the properties I talked about. So this goes in most of the lenses. Now let's go to the other multifocal lenses. So this is a case where this 67-year-old lady with bilateral cataract, and patient wants spectacle independence. Now this why it is being written is, this is very important. Patient has to demand something. You have to tell in counseling, that is very important, but patient also demands something, that he wants spectacle independence. Housewife, loves to read magazines, doesn't drive. Again, very important, because you need to know whether halos or glare will be there, and wants to do near work and watch TV. This is the ideal case for a multifocal lens. Now multifocal lenses, they desire spectacle independence, have in patients which have been myopic and enjoyed being glasses free for reading, will accept a slight drop in optical quality, does not do much of computer laptop work, engaged in nighttime reading, and cool, composed, cooperative personality. This again is very important. If a patient is fussy, you don't go in for a multifocal lenses. So this is why we chose a multifocal lens here. Now here the diffractive multifocal has been chosen. You see there are two different near and distant vision, two spots out here, the focal spots out here, and but these have some disadvantages where they create a halos and a glare and reduce contrast sensitivity, and most important what we have talked about, problems with intermediate vision. So it reduces the tolerance to astigmatism also, because rightly said, we have to use toric lenses whenever there is a bit of astigmatism. So this is a second case where a young patient, congenital cataract, is a garment businessman. He drives at night and loves to have off road drives. Extracurricular activities, young patient, table tennis and running. We considered for an EDOF lens here. Now EDOF is extended depth of focus lens. This implantation was done and patient is 6, 6 and 6 for initial 3 months, but reduced to N8 after 3 months. Now this is the intermediate vision in this patient is excellent, because this is what the EDOFs do. This is another example of a simple EDOF where a symphony was implanted. Here again, the patient wants to drive at night, and extracurricular activity is like golf and tennis and all. Now, why EDOF or ERVs? Again, patient has to desire a spectacle independence. Mainly, we use it for working professional with active social life. Near vision is mainly mobile phone users with occasional reading. You know, they are not good for a near vision. They are more better for an intermediate vision, ideal for corporate executives, doctors, surgeons, housewives, professional photographers, and they are desires good optic quality with minimum glare and halos. The glare and halos are less as compared to the multifocal diffractive lenses which we talked about. This is a diffractive lens which is available. One is the Symphony, other is the Vivity from the Johnson and Johnson. So they both have a different technology here. This is the, I am not going to the videos. This is something the congenital cataract which was implanted with Vivity, and patient is happy. But again, with an add of around 1.25 for near has been added after 3 months in that young patient. Now, this is another case where a 52-year-old male patient, IT professional, and bilateral cataracts, works on all digital devices and drives at night. Bilateral synergy implantation was done. Now, what is synergy? Synergy is a, sorry, no, this was bilateral panoptics was implanted in this. This is a trifocal lens where you have 3 different focuses and 3 discrete focal points for distance, intermediate and near, and they give a higher spectacle independence, and mainly used for all these people who want to be very active and want to have a near vision also, because if you are reading more, like you know, most of us offices and all that doing work, you need these type of lenses here. So patients who do frequent work on computer, laptop, like office-based professionals, account data inputs, now they need constantly shift focus from computer screen to reading material. Now all these are the patients which are to be counseled for the trifocal lenses, and like they are not involved in precision work like machinery, because very near work, if we are doing even with the best of the trifocal or multifocal lenses, it will be very difficult to do that, because near vision can't be the perfect here. And for all the patients, it is important that to choose who are not high strung, anxious, and they have a realistic expectation, like, and open to counseling. Rightly mentioned before, it also is very important. Spending a lot of chair time before the surgery is definitely important, and if you spend a lot of chair time after the surgery, that will make the patient anxious. So this is video I'll skip, and this is another case. So here was the case when synergy was implanted. Now again, household activities are needed. Time watching TV teaches children social activity, cooking, driving, you know, playing board games. Now 61-year-old female, active in life. Definitely, this was the vision pre-operative, post-operatively. Patient is having N6 vision and good intermediate vision. These are the continuous range of vision IOLs, combination of what you can say a trifocal and extended range of vision IOLs they have made and combined, and they leverage benefits from both ERV and multifocal or trifocal technologies. So they gave us a continuous range of vision without drop off fluctuation plus higher spectacle independence. So this synergy is one of the lens which is being used by me. Just wanted to show that lens is just a simple, just like a Technis lens, and it can be implanted very well without any hesitation. So there is no learning curve involved here. This is just a simple lens. Only thing is you should know how to center the lens at the end of the surgery, which is important. And once it is loaded in the injector, you can simply insert it inside the eye. So this is simple insertion, and we all must go back and start using multifocal lenses if we are not using. This is again a same case where Triumph lens was implanted. Now Triumph is a lens from BVI, so no financial interest here. This is again a continuous range of vision lens where it is a combined technology between a trifocal and extended range of vision lenses, and the patient is again very happy here. So now this is a case where I'm talking about here the new concept which I told about, the monofocal plus. This is a 72-year-old male patient diagnosed bilateral cataract, has glaucoma, right? And cup CD ratio is around 0.5 to 1, and wants spectacle independence, but because he has a glaucoma, we are not going here for a multifocal lenses. We plan for a monofocal plus lens. Now these lenses are very good. They give a lesser dependence for presbyteric glasses for reading, at least 45 50 centimeter. They can't be for 30 centimeter, and patients are extremely happy because they get a good intermediate vision, and the look on the is just similar to a monofocal IOL. There are no rings inside, so there are no glares and halos. Comparatively, they are comparative to any monofocal lenses. So this is one of the lens which hence you can see the beam split function here, how easily it extends to the far and the intermediate vision here. Now this is something which I wanted to show. This was implanted in a glaucoma patient because so easily it can be implanted. Here we don't want to use any lens which will further, we are not able to, patient will not be happy with the multifocal lenses here because the vision will be compromised because of the damage in the disc. So again, simple insertion, no learning curve here. Go back, use these lenses, again very important lens. And this is changing most of the monofocal practice in my hospitals to these monofocal plus. Last is a case of a patient with has a traumatic cataract. No, this is the same. We'll use another monofocal. We have used here monofocal plus. This is interesting where 77-year-old, my senior, a pediatrician, practices 3-4 hours a day, very active in participating in the IMA activities and meetings and all, and has been hyperopic, wearing glasses for 60 years. Now, pseudofoking one eye, the doctor never told him about a cylinder which he is carrying of 1.5 still having. Other eye has a cataract with a cylinder of 2.25, and he doesn't want a multifocal lens. Now, there patient is very categorical, doesn't want, and we also don't want to give it because there is a mild ERM in both the eyes. So here, Technis eye hands, again, the similar monofocal plus lens was given, and now can read at 60 centimeter, but near we need a 1.5 diopter glass is given. So, sorry, this is toric was implanted. Toric has been told and will be explained now in the future slide. So, for toric, my one-liner will be, it is a right of the patient to correct the astigmatism. All of us should go and do toric lenses, and it should be at least 15 to 20% of our practices. Don't think whether it is an Indian toric or an imported toric. Go and correct the toricity of the patient. So I'll skip this. Thank you very much. Sorry for the delay.
Thank you so much, Dr. Sharma. That was a very comprehensive talk on what would you do holistically for a patient. We now have our next speaker, Dr. Shail Vasavda, who is a very prolific cataract and refractive surgeon. Every time we are presented with a new type of lens, the EDOF or the extended range lenses, we are led to believe that, this is the lens and everyone must have that only. So what we want to learn is that, is it for everyone? Should we just put EDOF lenses for everyone? Dr. Shail will speak more about that. Over to you.
Thank you very much. And excellent talk by Dr. Sharma, who has laid the ground very nicely for the different varieties of IOLs and the different patients we can choose for each of them. I think the number one reason why surgeons hesitate to implant multifocal IOLs are that they don't want the headache post-operatively, that the patient may come with complaints of photic phenomenon, complaints of poor quality or waxy fluctuating vision post-operatively, and that's probably the major hesitation that all of us have had. With extended range of vision and the variety of lenses that were there previously, the past experience was mixed, particularly with many of the EDOFs that were existing were still diffractive ring EDOFs like Symphony, and therefore the photic phenomenon problems did not disappear. So you still had to counsel them for glare, halos, so on and so forth. And with introduction of good trifocal IOLs, the patient happiness quotient has gone up so much that there's again now a hesitancy that why we should be going and thinking about an EDOF again when the trifocals are working very well. So I think extended range of vision is something which is here to stay, because with increased life expectancy there is increased period of active life, and everyone who is educated, non-educated, urban, rural is on a smartphone and using screens left, right and center. But not all of the patients are suitable for trifocal IOLs. But believe me, everyone wants to, if possible, at least use their phone or read their WhatsApp without glasses every day when they wake up. So what actually is an extended depth of focus IOL, and this is what the FDA approves, and what it categorizes as an EDOF IOL. So any IOL which gives more than half diopter improved range compared to a monofocal control IOL is considered to be a extended depth of focus IOL. And there are several types of extended depth of focus IOLs, including the small aperture IOLs, which are usually suggested only for unilateral implantation, low at diffractive extended depth of focus IOLs, which have the limitation of photic phenomenon, and now newer generation wavefront shaping and spherical aberration modified EDOF IOLs, which reduce the or eliminate the need of rings, and therefore the dysphotopic phenomenon like can be seen in this slide are far and few in between. So the major advantage of an extended depth of focus IOL is that there are no dysphotopsias that we need to be concerned about post-operatively. The disadvantage is that yes, they are not meant for spectacle independence across all distances. So you will have variably patients requiring glasses, particularly for fine print, ranging from 0.75 to 1.5 diopter from eye to eye. In our practice, and it should be across everyone, is that pre-operative workup remains equally thorough. It has to be as if you want to evaluate each eye, it should be suitable for a trifocal or an EDOF. And still, healthy eyes are still the best candidates for any form of these extended depth of focus IOLs. We'll go through some case scenarios. So this was a 56-year-old male. Ahmedabad it does have a lot of industries which are just 20 to 40 kilometers away from Ahmedabad. So he's a manager in one of these factories. He's a myope since a young age, and he's now struggling or is disturbed with glare while night driving, and because of which he now has to carpool with his colleagues, particularly while coming back, because when he comes back the road is not a proper highway, it's a single lane road, no street lights, so on and so forth. So myope with nuclear cataract, his main activities are supervision of the field force, so he's not actually the technical person performing it. Checks daily logs, he drives back to the city through the country roads, so as to say, and he wishes less dependence on glasses, but he doesn't like to carpool and he would like to continue driving as long as he possibly can. So since glare and night driving are his primary concerns, therefore trifocal is not suggested in this case, and we decided to go ahead with a bilateral vivity in this case, an extended depth of focus with a target of emetropia in both eyes, as distance vision is of predominant importance. We explained to him that he will need glasses for reading, but the dependence will be less compared to a monofocal IOL. Post-operatively, he did very well for distance, intermediate and near. And in our office with bright light and good contrast, he manages to, with strain, read N6 also. So he tells us that in his functional life, he's able to drive comfortably now on his own. His reading vision is fairly good. He says he hardly ever needs to use reading glasses. He uses them mainly while actually checking the numbers, checking the bills and accounts. And he uses about 1.5 diopter, 1.25 diopter reading ad for this purpose. The other concern that we had was that when there are these modifications in the central optic of the IOL, does it actually affect the aberration profile that is going through this eye? So this is that same patient to show that the internal aberration of coming from the IOL is negligible, which means that even these modifications that are being done on the surface of the IOL are not causing any changes into the internal aberration profile. Another case of a 64-year-old lady actively does stock market trading and analysis on her desktop. Very well to do, but children are settled abroad, and husband is suffering from chronic ailments, almost bedridden, doesn't drive. So she's the main person running the house. Hypermetropia with presbyopia, she's keen on spectacle independence but doesn't want to compromise on quality of her vision because she knows she has to hold the fort at home. So in the first eye, we decided that we might go ahead with an extended depth of focus VVT, and we chose target emetropia, and like in this case 24, and we discussed that we will see how the outcome of one eye is, and if we want to consider a slight myopia in the other eye. This is just to show the changes on the surface of the IOL that are there on the VVT. These are the ones that are responsible for causing the extension of focus. Post-operatively, she's doing very well for distance and good in intermediate and fairly decent near vision. So for the second eye, instead of going for 22, we chose one target more, that is minus 0.5 diopter of myopia for the other eye. Keep telling her that not to compare both eyes, and she did extremely well post-operatively, binocularly for distance as well as near, and she hardly uses glasses post-operatively. The only time she uses them are for reading the expiry dates on her husband's medicine sheets. And there are now articles in literature to show that if you do a slight target myopia in the other eye, you can consider it improves the near range of vision. So the 52-year-old ophthalmologist, active cataract surgeon, unilateral PSC, and he goes to a peripheral center once a month, drives on his own, of course, like most of us, as a visiting surgeon to a nearby town. His otherwise ocular profile is suitable. He's unilateral cataract. He doesn't implant too many of these IOLs in his own practice. He was considering the idea, his colleagues had suggested that you can consider some of these monofocal plus or EDOF IOLs, but he was very sincere as a unilateral cataract. So we had a detailed discussion regarding the pros and cons, and we went ahead with the VVT in his unilateral cataract eye, and he has excellent distance and intermediate vision, and he says that he's able to drive on the highway very comfortably even at night, and he hardly ever uses glasses when he's at home except for reading the newspaper. Doing very well and no problems even while operating cataract surgery. Another 60-year-old ophthalmologist, very active cataract surgeon, we did a toric monofocal for him in 2017, myope, and he's using post-operative progressive glasses. And now he's come for his left eye, and he's himself very keen that, I would wish if I can reduce or improve my intermediate range of vision so that in my routine functional life at home, I'm less dependent on glasses. So once again, we discussed the pros and cons that you have a monofocal in one eye. We can consider, we feel this should work binocularly quite well. Do not compare the vision between two eyes, and you'll still need, particularly for near work, glasses. So we went ahead and did an VVT in the other eye of a toric monofocal in the other eye, and here you can see in the undilated state, it's very well centered and the IOL is well placed in its axis, and post-operatively, he's extremely happy subjectively, and he personally doesn't find any much difference binocularly when he sees with both eyes open as far as the quality of vision goes across his differences. So these two cases to highlight that you can consider EDOFs in a unilateral cataract or also for the second eye of your own pseudophakic patients in whom you have done a monofocal preoperatively. A 73-year-old gentleman, bilateral cataract, retired but active. On OCT, he had a fine ERM. So these are the eyes, like Dr. Samresh showed, you don't want to consider for trifocal IOLs. And therefore, we explained that because of his retinal condition, he is not a suitable candidate for trifocal IOLs, but you can definitely consider an extended depth of focus IOLs, which we did, and his quality of vision is very good, and he requires 1.25 diopter add for fine print. Another 83-year-old, very healthy, no diabetes, no hypertension, and she stays 9 months out of 12 in Canada with one of her sons, and 2-3 months here she comes here to her daughter. She uses iPad a lot in Canada. Nuclear cataracts, and unfortunately she has dry ARMD in both eyes. She would love to be spectacle independent because that's the only thing that she does at home. But she has drusen, so therefore trifocals was out of question. But having some experience in retinal eyes with EDOF IOLs, we did consider and discussed with her that you may need some extra light, your contrast may drop, and you will still need glasses for reading, but your dependence will reduce significantly. So we went ahead with bilateral Vivity, and she's extremely happy. She's N8 for near, and she doesn't use glasses. She says she's very comfortable using the iPad with an increased font size, and this is just to show that her contrast sensitivity with and without glare has also not been compromised and is similar to a monofocal IOL. Last case of a 17-year-old girl presents to us with decreased vision, known case of glomerulonephritis and long term on oral steroids. She's developed now, she's high myope with astigmatism and developed a steroid induced PSC. So we decided that we will consider doing a Vivity toric for her, and because these patients are likely to require YAG post-operatively, with our experience of doing PCCC in pediatric cataracts, we generally do PCCC even for older children, so that the need for YAG and other complications of YAG are eliminated. So here we are performing PCCC after a flax perfectly centered ACCC has been done. And this is just to highlight that even with an open posterior capsule with a PCCC, you can still go ahead and safely place these toric EDOF lenses in the bag, and they will remain centered and they won't rotate overall in the long run. So post-operatively, this girl is doing very well. And she uses glasses mainly for her reading activities, but when she goes to her pre-college, which she is now in, she hardly ever uses glasses. Just to show that even in radial keratotomy cases, if the astigmatism is regular and the topography is regular, using these ASCRS calculators, you can achieve reasonably good outcomes. So therefore, evaluating such eyes is of extreme importance to show the RK cuts. And the contrast sensitivity is also not affected with these EDOF IOLs. Other scenarios where these EDOFs can be considered are low grades of Fuchs dystrophy or early to moderate glaucoma. So I think the EDOF lenses, they do deliver what they promise, excellent quality of vision for even precision oriented individuals, compatible with unilateral cataracts, no dysphotopic phenomenon, surprisingly good near functional vision even with bilateral emetropia, and some mini monovision can be considered in eyes who are willing to accept that. But they are not meant for those who want no glasses. So if somebody says, I don't want glasses for reading, this is not the lens for them. Because most of them will require glasses for fine print reading, and it could be as high up to plus 1.5 diopters, and some loss of contrast in dim light, but it seems to be working well even in eyes with relative comorbidities like ERMs, ARMD, post LASIK, post glaucoma, so on and so forth. But I think that will still require more experience. So I think we have a good addition into our armamentarium, which seems to be working well across all ranges and can be considered even for select comorbid eyes. Thank you so much for the patient listening.
Yeah, thanks a lot, Shell. And I think over the last few years of our usage, the two audiences that I really feel this lens works is one in young patients who come for cataract, because a lot of patients in their mid 40s and all don't really read print as much these days. So that near vision cell phones, you can always increase the font by 1 or 2, but because they don't read print and their work involves more distance and intermediate, this in my hand tends to work very nicely. And the second, like Shell brought about, those mild comorbidities, early glaucomas, early query RMs. So there's a lot of clinical judgment involved over there. But that's a segment which was otherwise absolutely, a no-no for multifocality. And now they do have a possibility of getting that benefit of a little bit of range. So with that, I'd like to invite Dr. Laja Shastri, who's a pillar at Raghudipai Hospital and is very key to our counseling strategy and explaining to the patients how all these technologies will help them in day-to-day practice.
Thank you so much. Yes. So the question is it even possible to have a situation where we can consistently ensure that we do not end up having that nightmare of facing an unhappy multifocal IOL patient? Yes, it is possible. With the past 2 decades of extensive research, we have managed to build up a fairly comprehensive list of factors that include patient factors and ocular factors, which when evaluated in time and evaluated thoroughly, can actually help us prevent that unhappy situation. Since I cannot possibly talk about all of them, I'm going to share with you some actual patient experiences that will highlight the impact of those ocular factors on the ultimate outcome. The first patient I share with you was a kindergarten teacher who came to us complaining a lot about her foreign body sensation and watering and photophobia. So, a lot of ocular surface symptoms in addition to blurring of vision. The history is that she has been a myope all her life, and all her life she has only used contact lenses all day long. Until recently, when she was told by somebody that she has cataract in both her eyes, and she comes to us very eager to get cataract surgery done. She's using cataract as an opportunity to get rid of her glasses and contact lenses forever. So she's like, doctor, just go ahead. I want to get my cataract surgery done. When I start evaluating her, what I find is completely bizarre corneal aberration profile, which is not surprising. On tearfilm evaluation, I find that this surface is not even suitable for evaluation, let alone surgery. So I decide to postpone her surgery and I'm going to put her on aggressive topical treatment for her ocular surface. Am I going crazy? This patient wants to get operated like yesterday and I'm planning to postpone surgery. Is she going to run away and get operated elsewhere? Here is a very, very important lesson learned that I have in the past couple of decades, that if we sit a patient down and if we explain to them what we are doing and why we are doing it, nobody is going anywhere. They are going to come back to us and actually respect us more for giving their best interest a higher priority. So when I explained the situation, she agreed to wait. And what I'm showing you here is post-treatment, before and after treatment. As you can see here, a completely changed aberration profile, a much better cornea now. On evaluation, when we find her to be suitable for a trifocal and when we give her that option, she jumps to it because she wants to get rid of glasses for distance and near both. So after both eyes trifocal lens implantation, extremely happy with her outcome, saying I've never seen so well without glasses ever before in my life. A very, very important lesson learned in this very happy story is that ocular surface disorders are becoming extremely common in our patient population. This one was because of extensive contact lens use, but I'm sure you would all agree, so many patients are coming up with varying degrees of MGD problems. The reason this is a big problem is because it can cause increased stray light. At any cost, we always want to avoid increased stray light for every patient, but especially those with a multifocal lens. Why? What is so wrong with increased stray light and what is an increased stray light? To give you a brief idea, and this is something made by Dr. Samresh, so well demonstrated animation, whenever there is any irregularity on the surface of the eye, it could be epithelial degeneration or a poor ocular surface or just a small nebular corneal opacity, then whenever that irregularity overlying the pupillary area gets hit by the light rays, they get diffracted every which way, get scattered all across the retina, forming this thin veil of light, which is what we call increased stray light. Now, what this will do for the patient is that if this is what was seen by a person with a normal ocular surface, the same thing would appear like this for somebody with an increased stray light. Imagine this degree of glare and visual quality degradation. Any person with a multifocal lens with this kind of a surface will blame the multifocal lens and will make our life a nightmare. So we must pick this up in time. Also, like what Dr. Samresh mentioned earlier, it can cause an unreliable biometry. It will cause change in the IOL dioptric power calculation and will result in residual refractive error. So not only does an ocular surface disorder cause ocular surface symptoms, but it can also cause glare and can also result in a residual refractive error. All the things which are a perfect recipe for a patient becoming very unhappy with us. The second patient I share with you is a homemaker who comes to us unhappy following one eye cataract surgery elsewhere, saying that she's unable to read on her mobile. She's like, there's so much strain, I can't read very well. And although she herself does not drive, she feels that whenever she is sitting next to her husband and when they go out, she is very uncomfortable with the lights of the oncoming headlights of the cars. Now, when I look at her visual outcome in the operated eye, which is the right eye, and when I ask her if she's using any glasses, she tells me that why would I need to use glasses? I am told that I have a multifocal lens implanted. I will not need to use glasses either for distance or for near. Now, with this information, when I look at her refraction, what I find is that her vision improves to 6.6 with astigmatic correction and N6 with a low add power. On slit lamp evaluation, I don't see any diffractive rings because it is actually an EDOF lens. It is not a multifocal or a trifocal lens. Now, what this trifocal lens, EDOF lens is doing is that, as you can see here, in significant number of clock hours inferiorly, the anticapsule rhexis margin has slipped off the optic, fused with the PC, and this is causing the IOL to tilt a little. To demonstrate on aberrometry what this lens can do, this slight bit of tilt. This slight bit of tilt is causing, and these are the internal aberrations, presumably stemming from the EDOF lens, are actually causing so many higher order aberrations, also inducing astigmatism. But otherwise, this eye, operated elsewhere, is completely suitable for a trifocal lens. Now, with this in one eye, when we evaluate the second eye for which she has actually come to us, what we realize is that she's suitable for a trifocal toric lens. Since she is somebody who wants to be able to read well, and she has come to us so that, make sure that, the same problems don't happen in the second eye, we tell her that we can put a trifocal toric lens in the second eye, provided you do not compare your vision. We don't want you to keep comparing your right eye, left eye. We want you to use your binocular vision, and that whatever we are planning to do in the second eye should be able to address your problem. Following trifocal toric lens implantation, fortunately, an emmetropic outcome for which she is very happy about, but she's actually very happy about the binocular vision. Now she does not feel the necessity to reach out for glasses or not being able to read on her mobile. So very, very important lesson learned is that whenever a patient has been told that they receive a multifocal lens, if the visual outcome unaided is not all that good, it is going to be an unhappy patient. Let's not underestimate a homemaker. It could be a CEO, it could be a homemaker. Everyone has a right to expect the kind of outcome that we had promised. So making sure that there is no residual refractive error causing a poor unaided visual outcome is very important. Also, optimal surgical outcome is an absolute must. And when I say this, I don't just mean clear cornea day one. What I actually mean is that when we leave behind a lens, any lens, but definitely a trifocal lens, it needs to be covered 360 degrees by a anterior rhexis margin, symmetrically holding this lens in the bag, such that the effective lens position for which we had used an IOL calculation formula and we had chosen a particular IOL dioptric power, that effective lens position is achieved and maintained. So we need to leave behind the lens in a correct manner for it to do a proper job of reaching the kind of refractive outcome we want. Also, trifocal lens and an EDOF or an extended range of vision lenses are not interchangeable. They each have a completely different visual performance spectrum. So we need to spend time with the patient, understand what is it that they want, what is the eye suitable for, and then match the lens with that particular eye. The final patient I would share with you was a little different compared to most others in the sense that he came to us all the way from another city to just get our opinion on the eye that he was very unhappy about. He was so unhappy with the multifocal lens he had received, and he was so convinced that there was something grossly wrong with his surgery or the lens that the operating surgeon himself suggested that, please go and get a second opinion. Now, since he unfortunately chose to come to us, the operating surgeon called us and told us, gave us a bit of an information why this patient is coming to us, and told us that, the surgery was fine, the lens is fine, there is no significant residual refractive error. I don't know why this patient is so bitter and unhappy with us. Now, when this patient walks into the consultation room, he looks like somebody's very benign grandfather, but the minute I ask him what his complaint is, in a fairly aggressive manner, in an increasingly louder decibel of voice, he describes in some great detail 10 different activities in his life where he finds his vision to be completely unacceptable. All his problems indicate that he is actually finding his vision to be hazy, and especially whenever there is low light, he's finding it very difficult to navigate. When we look at his visual performance, it's not all that bad. There's no residual refractive error as such. When I ask him if he's using any kind of topical treatment, he pulls out a note from the referring surgeon, and which tells me that this patient was found to have raised IOP during pre-op evaluation. And at that point in time, he was put on a PG analog for both his eyes, which please note, he's putting a PG analog in the operating eye, which he has been putting throughout surgery and post-operatively, and found to be well controlled with that drug. Also, the surgeon notes that although he could see the fundus, the details were not very clear because of the advanced nature of the cataract. Now, with all of this in the background, when I actually examine him on slit lamp, completely pristine corneas, quiet anterior segment, very well-centered trifocal lens, on aberrometry profile, there are absolutely no red flags, nothing going wrong with this eye. So what is the problem? Why is he so unhappy? The problem we find on dilated evaluation, significantly high cup disc ratio, 0.7, 0.8 CD ratio in both his eyes, with a dispeller which is significantly more in the operated eye compared to the other eye. So what we are looking at on PSOCT is a compromised optic nerve, which we could see on routine fundus evaluation also. What is happening here is that glaucomatous optic nerve damage done to the optic nerve of the eye, which is operated, which is causing poor contrast sensitivity, added to which there is a trifocal lens which has diffractive IOL optics, which also further lower the contrast sensitivity. Combined together, he's extremely unhappy with the quality of vision. So a very, very important thing, and I cannot emphasize enough how very important it is, that if at any given point in time preoperatively, if there is a reason to believe that this eye could have a suboptimal visual potential, either due to a diseased optic nerve or a diseased fovea or macula, it would be so much better to err on the side of being more cautious and not implant a multifocal lens of diffractive nature, even if the patient insists on it and even if he's very motivated, because it will compromise the quality of vision that they will be unhappy about more often than not. And one very, very important lesson, like what Dr. Samresh also mentioned, preoperative PSOCT evaluation, I cannot tell you how many times it has saved me from a very embarrassing result and an unhappy outcome. Getting it done for every patient, at least planning to undergo multifocal lens evaluation, would be a very important thing to do in order to ensure a happy outcome. I could go on, but finally I would just say that devil is actually in the details. So if we keep all these factors in mind, if we take the time to thoroughly evaluate the eye on slit lamp, examine the eye properly, making sure we spend time talking to the patient and understanding them, then it is not all that very difficult to make sure that every patient is actually very happy with their outcome. Thank you so much.
Thank you very much, Dr. Lajjavan, for sharing how to evaluate a patient who is not happy with the outcome. And like we correctly said, that before blaming on the personality, let's first objectively rule out the possible causes that can be there for unhappiness. I would like to value Dr. Yes, sir. Questions.
I think I'm audible.
Yes, sir.
KPS Malik, ma'am.
Yes.
Ocular surface disorders,
Yes.
trifocal lens.
Yes.
You corrected ocular surface disorders. Would it not recur?
Which is exactly what I said, that if we believe that we can treat it is when we actually, this particular case was because of extensive contact lens use. But if we believe that this is a severe case and cannot be treated, we must absolutely not implant a multifocal lens.
That's what my point
So
is.
you are absolutely correct, sir.
Yeah.
We must absolutely not implant it if we believe that we cannot actually treat this problem.
And I have trifocal, I can see very clearly.
Wonderful to know that, sir. Dr. Ramamurthy, sir, what would be your opinion with the advent of trifocals? Do you find the unhappy patients are reducing, increasing? We somehow find that they are reducing than what they were before.
Absolutely. I think that with the current crop of trifocal intraocular lenses, at least as the problems as far as the range of vision is concerned, the ability to read from near, intermediate and distance is quite adequately addressed. But as far as the problem of dysphotopsia is concerned, I don't think that has completely gone away. But still, most of us remember that occasional patient who is taking a lot of chair time and coming back to you with complaints. But there are hundreds of patients out there whom you have operated who have bilateral trifocals or even the earlier multifocals who are quite happy. Years back, when we had just the array multifocal, we did a thesis for one of our postgraduates on bilateral implanted array multifocal. And what we found was that 96% of the patients were quite happy with the multifocal lenses, and they would have the same lens again if they had a choice. So now, obviously, with the better understanding of optics, much more hand holding as Dr. Lajja explained, we find that majority of our patients, if preoperatively, intraoperatively, postoperatively have been taken care of optimally, end up with a very good results. It's only the occasional patient whom we cannot identify, whom we always remember and talk about.
Thank you very much, sir.
Excuse me, sir, one
Yeah,
question.
please, please.
Sir, I have in one of my patients, I have implanted bilateral trifocal panoptics lens. The patient always complains that in one eye she is very comfortable, the other eye is heavy. I don't know why. Maybe the negative dysphotopsia is working in that patient. Everything is fine. Vision is 6 partial and N6. She's saying having no problem with the vision, but the other is heavy. It's not, I'm not feeling normal in that eye. Maybe a negative dysphotopsia in that patient. How to counsel that patient?
I would actually strongly recommend an ocular surface evaluation. Ocular surface not being well will always result in all these kind of very vague symptoms which we'll never actually be able to quantify. So if you just do a simple tear film breakup time, you might somehow, after cataract surgery, we have been putting so many drops, steroids, NSAIDs, just because the person is the same person, if their both eyes don't respond the same way to the medications. And sometimes just treating that ocular surface might actually just treat the basic problem that she's facing of the heaviness in her eyes.
One is okay. We can say one is ocular surface disorder that we can rule out. Suppose the patient is saying I am having heaviness in this corner of my eye. How to counsel that?
So is it the second eye, the heavy eye?
Which one? The second eye.
Second eye. No, that's always the second eye which is heavy. That's why I wanted to know. Yes.
So I think what Dr. Lajja correctly said, if we rule out everything, negative dysphotopsia is something little different. They will complain of something obstructing their vision. So there are patients, like you correctly mentioned, who have such vague symptoms where we find nothing is wrong in all parameters that we check. And then I use the trick that we have learned so well from Dr. Ramamurthy over the years in our courses, that hand holding the patient and just explaining to them that there's nothing seriously wrong inside their eyes which is likely to affect in their long run, and just sort of, counseling them that time should take care of most of the problems that you are facing. That's probably the only thing that.
And negative dysphotopsia is just an arc of light that the patient, rather arc of absence of light that the patient perceives temporarily. If you want to rule that out, all you need to do is to ask them to keep a hand temporarily like that. Immediately, if they find that that symptom disappears, then that's negative dysphotopsia. But otherwise, this vague complaints is not really anything to do with negative dysphotopsia.
I would like to ask the panelist, how many of you surgeons use preoperatively also the drops, like lubricating drops and cyclomion, and how long you like to continue? Or if you're not using, why you are not using?
So as a general rule, if there is no gross dry eye or no ocular surface symptoms, in our practice at least, we do not use cycloimmune as a routine for sure, and not even lubricants as a routine pre-operatively we don't start for all patients. I would value...
And post-operatively, sir?
Post-operatively also, if there is no gross ocular surface issue or no symptoms, as a routine, as a blanket, we don't give lubricants to everyone. But I think giving a lubricant post-operatively is not a bad idea to make sure these...
Sometimes these patients do want a long-term drop solution. So because we are bombarding them in the first 2 weeks with antibiotics, steroids, in our practice also cycloplegics. So after 2 weeks, we normally, if at all, put them on some lubricating therapy. But apart from refractive patients, if it's a refractive surgery patient, then yes, particularly if it's surface ablation, we put them on cycloimmune. But otherwise, no.
But what we didn't really explain was that we typically choose to preoperatively evaluate a patient at least few days prior to surgery. And every patient will undergo a tear film ocular surface evaluation also. So if anybody was found to have a requirement of the sort, then they would definitely be put on it. But as a blanket, it's not given to everyone.
Just to add little bit to that one eye is feeling heavy and another is all right. The vision is okay. I think one has to tell that God never made both eyes equal.
So
God
true.
never made both eyes equal. Tell that even pre-operative, that one of the eyes may be better than other. Whatever you do, and this is fact.
Wonderful, Pearl, sir.
Absolutely true, sir.
Now I'd like to invite Dr. Ramamurthy, sir, to talk to us about how to go along and what are the tips to be successful with toric IOLs.
Thank you so much, Shail, and it's indeed a honor to be a part of your course. And we have had this association for many years. These are just enumerating a few tips that I routinely follow in my practice. Do not use refractive astigmatism. All of us know is the corneal anterior corneal astigmatism, which is most important. And just using refractive astigmatism may mislead you. This is just to show you the eye trace pictures. You can see this is from the internal optics, and this is from the cornea. The cornea is absolutely pristine, and this patient was wearing minus 1.5 diopters of power in the glasses right through the life. But the entire thing is coming from the lens, and in this case, when the cataract surgery is done, obviously this patient doesn't require a toric intraocular lens. On the other hand, you can have, these are practical examples, you can have a situation like this where the lenticular astigmatism and the anterior corneal astigmatism almost tend to neutralize each other. So once the lens is taken out, this corneal astigmatism is going to become manifest. So you definitely need to have a look at the spectacle power, the kind of cylinder that has been there, but do not be guided by that as far as the decision to implant a toric intraocular lens is concerned. It's essentially the anterior corneal curvature which is most important in determining this. Using the right instrument and the right formula is extremely important for biometry. And there are multiple formulae that are available to us, and every conference we keep discussing about what are the advances, the nuances, what is the differences. But as a guidance across all our centers, we use the Barrett-Suter formula, which almost takes care of all our requirements. And our go-to formula as far as the evaluation of these patients is not the Barrett Universal 2 formula, but the Barrett toric calculator, and that's the primary formula in which we do all the measurements. It is simply because of this reason. As far as the Suter formula is concerned, it is available in the IOL master, various optical biometers. But just in case you do not have access to them, you can still benefit them from these formulae at the ASCRS and APSCRS websites, where it's available as a drop-down menu. You can see a situation like this against the rule astigmatism of just 0.6 diopters. Oftentimes I am asked that what is your cutoff as far as putting a toric intraocular lens is concerned. It is not just the magnitude of the cylinder that is important, it is also the axis which is extremely important. This is against the rule astigmatism. Just for a 0.6 diopters, it shows up a need for a T3 toric intraocular lens, and especially if it's a multifocal lens, it's definitely this needs to be taken care of. On the other hand, you look at the oblique astigmatism or with the rule astigmatism, this is a little more. Instead of 0.6, it's 0.68. But what the Barrett toric calculator is telling me is that this patient requires a non-toric lens. So that initially we are doing all our calculation by Barrett Universal 2, and then the patient will be counseled for a multifocal intraocular lens. When we look more deeply, we'll realize the patient actually requires a multifocal toric intraocular lens. So recounseling, the cost goes up, the patient is a little upset about it. Why was I not told this earlier? So that's the reason, as soon as the patient is decided for cataract surgery, even before he or she meets the counselor, we do this biometry and subsequently decide on this. I'm sure many of us are there. We have our own centers where some of them do not have an optical biometer, and this is the drop-down menu that's available in the APSCRS website right in the opening page, and you can have easy access to that even if you are not a member, and use the benefits of this. In case you are taking your measurements with immersion A scan and an auto keratometer or even a manual keratometer, the only thing you need to remember is that you need to use the acoustic A constant and not the optical A constant, in case there are two different A constant for that particular eye. Using that same, you can see over here, this is against the rule astigmatism of just 0.75 diopters, and what the formula tells me is that the patient needs a T3 toric intraocular lens. On the other hand, exactly the same amount of astigmatism, mind you, this is not on the optical biometer, but it is in the website, 0.75 diopters at 90 degrees, and what you need is a non-toric intraocular lens. So don't go with the cylinder in the spectacles, don't go just by the magnitude of the astigmatism, feed it into the formula and let that tell you whether the patient needs a toric or a non-toric intraocular lens. Obviously, this must have been emphasized even in this course, that correcting low astigmatism whenever you are resorting to any type of multifocals or EDOF lenses is extremely important. Let me illustrate this with you with an example. We had this patient of 0.87 diopters at 18 degrees, a reasonable amount of cylinder. That was a time when the trifocals were just coming into the market. We thought it's already an expensive lens. Making a trifocal toric is going to make it more expensive. Patient was planning to get both eyes operated. So he said, why just a diopter of astigmatism, less than a diopter? Let's go ahead and implant a trifocal, not a trifocal toric. And as you can see over here, got reasonably good near vision. Surprisingly, the distance vision was just 618. And you have this mixed astigmatism that is there, which was required for correcting the patient. It's not just the requirement for glasses, the quality of vision also deteriorates with this. But the patient was quite perceptive. We told him that wait for a period of 3 months. We ignored the cylinder, actually told him all the truth, and implanted this lens. But then you have this residual. We'll do a free laser vision correction at the end of 3 months and then take care of you. And while waiting there, because he was planning to get the surgery done in both eyes, a week apart, he said, like, he believed in us. He said, let me go ahead and get the other eye operated. And almost the same amount of cylinder in the other eye, 0.86. And then what we did is to implant a toric trifocal lens in this case. And you can see the kind of impact that it has, that where the cylinder is also completely taken care of with a 6.6N6. Actually, the patient decided not to undergo the laser vision correction with the other eye, simply because with one eye corrected so optimally, other eye working well, almost to 90-95% for distance, and he decided that he could live with this. And again, as was emphasized already, with the rule and against the rule, astigmatism are completely two different animals. And you can see this. I'm emphasizing this because we need to understand this. The posterior corneal toricity, which is most often against the rule, needs to be considered. And you have a 0.98 diopters of against the rule astigmatism, and what's indicated a T4 intraocular lens. On the other hand, if you have a with the rule astigmatism, even a 0.75 is a non-toric intraocular lens that's indicated. So not just the power, but the axis of the astigmatism is also equally important. Another very important point you need to understand is that for a sub 2.4 millimeter temporal clear corneal incision, which is my normal incision, the SIA is just about, the surgically induced astigmatism is just about 0.1 diopters. I used the Hill calculator, and for a long time I used to believe that my incisions are creating an astigmatism of 0.44 diopters, and I used to incorporate that, and that may be one of the reasons for the suboptimal outcomes I used to have. But today we understand, with the seminal work done by Graham Barrett, Doc Cock, etc., that astigmatism just doesn't have a magnitude, but it also has a direction. And in the various points on the corneal surface, I'm not going to go into the details, they tend to neutralize each other, because of which what we are concerned about is the centroid value of the total astigmatism that the temporal clear corneal is creating. You can customize your centroid value, but since it is just in the range of about 0.1 diopters, it's really not worth wasting that time. And there are surgeons who do not just feed in SIA as 0 diopter. So that is the reason doing your incisions on axis has also been almost completely given up. And at least in my case, for a 2.4 millimeter incision, I do it always on a temporal 180 degrees axis. The only time I make a variation is if I'm implanting a phakic intraocular lens, where more often in the younger patients we have with the rule astigmatism, the patient has about 0.5, 0.6 diopters of astigmatism. I make a superior 3 millimeter incision. And a superior incisions always create a little more astigmatism than a temporal incision, and that takes care of a small amount of astigmatism. But this is not applicable to cataract surgery. And repeatable axis marking pre and intra-op is both necessary. I used to think this freehand marking is something which is not really scientific, should not be done. But I visited David Chang almost 7-8 years back in his surgery, and what I found was that before every patient, all he was asking them to do was to look at his forehead and doing his freehand marking. Maybe he was an expert in doing that, but that's also one way of dealing with these patients. Otherwise, for a long time, we are using this bubble marker where it has to be absolutely perpendicular, parallel to the floor, and this bubble has to be in between these two lines. You get a mark on the 0, 180 and 90 degrees axis. Otherwise, I think if you do not have access to a digital marking device, then using a slit lamp before the pupil is dilated, creating a slit, cutting across the pupil, and I usually use a 26 gauge needle to mark, create a small subconjunctival hemorrhage over there, which will not disappear during the surgery. Of course, if you are doing a large volume of toric intraocular lenses, which I believe all of us should be doing and addressing them, whether you're doing multifocals or not, having access to a digital marking device like the Varion or a Callisto is a great way to go. And this is intra-op alignment. Let me just show you a couple of videos, very short videos. And this is when I'm using viscoelastic. A gross alignment is done. That's the temporal clear corneal incision. Getting a good rhexis is extremely important so that you have a good overlap. And that's the intraocular lens that's being injected in. And usually it's injected in such a manner that it's about falls shy of by about 10 to 15 degrees. These lenses can be rotated more comfortably only in the clockwise direction. And once you remove the viscoelastic quite completely, it's important that you remove the viscoelastic from the back of the lens also, and that's the reason I'm going behind. Also, do not overinflate these capsular bags, because if you have too much of fluid even behind, not just viscoelastic, there is a greater propensity for these lenses to rotate. And the final alignment is made, and even after the speculum is taken off, you have to make sure that the chamber is not shallow and the alignment is retained. That's extremely important. We did a study even comparing the manual alignment as well as the alignment using these digital devices. At least in our hands, we found that both of them worked equally well. So if you are reasonably experienced, it's not necessary that you need to have access to a digital alignment system. Nowadays, I'm doing more of this toric IOL hydroimplantation, and this is actually an Indian toric intraocular lens that is going in. And you can see it's a 2.8 millimeter incision. No viscoelastic is being used, and subsequently, with the maybe you might have noticed that I kept the IOP at 90 when I was injecting the lens because I wanted a well-inflated anterior chamber, and now I am exactly orienting the lens the way I want. The Varion overlay is there, but I need to switch the cameras to show that, and it will show up shortly. And this definitely reduces the amount of time taken for the entire surgery, and the need for removing the viscoelastics is also not there. And here I would like to mention a word about Indian and imported toric intraocular lenses. Obviously, the imported lenses are good. They have a lot of research has gone into it, and I am a high volume user of multifocals, torics, etc. But if in case you have a patient with a 1.5 diopters or 2 diopters astigmatism, he or she cannot afford a imported toric intraocular lens, we do not hesitate today to go ahead and implant Indian toric lenses. There are several manufacturers who come up with good quality lenses, and our cost of for the patient, the cost of an Indian toric intraocular lens and imported aspheric single piece lens is almost similar. So we'd rather give the advantage of the patient to neutralize the astigmatism rather than insisting just on imported lens being implanted. When there is a residual astigmatism that is there, these are the ways that by which you can deal with it, by IOL rotation, IOL exchange, piggyback intraocular lenses. Here again, the formula that we resort to, there is Barrett RX formula, and this works very well. Basically, this is a case where a 24 diopter T4 lens had been implanted, and the residual error, as you can see, is +1 diopter with 2.5 diopters. One factor that you do need to understand is rotation of these intraocular lenses will take care of the residual astigmatism only if the spherical equivalent of the residual error is almost zero. If supposing it was just a 1.5 diopters of cylinder, or if it was 1.5 diopters of sphere, rotation of this lens is not going to serve any purpose, simply because when you are rotating the lens, you are just redistributing the power and not introducing any extra power. But in this case, as you can see, the spherical equivalent of the residual error is nearly zero, so rotation will definitely help. And this tells me that rotating the lens by 6 degrees is going to take care of the astigmatism to a large extent, and that is exactly what was done. Just in case it's a very large amount of astigmatism, there's been some miscalculation of the patient has presented to you after a long time, then you can, IOL exchange can also be contemplated. The same formula can also give the benefit of that. If the capsule is completely fused down, still there is a certain amount of cylinder. Yesterday in our cataract panorama session also we showed this. Then it can be a piggyback lens also that can be introduced. This formula will tell you about that also. My final tips to maximize your outcomes as far as toric intraocular lens is concerned: take multiple measurements of the K reading, consider but do not be guided by refractive cylinder, check the ocular surface not just before the surgery but even before your biometry. The surgical induced astigmatism with centroid value is just 0.1. The posterior corneal astigmatism is to be considered by the formula. Most modern formula do that. During the surgery itself, create a little longer incision so that a rectangular or a near square incision so that they seal up very well. Avoid overinflating because we do not want viscoelastic or fluid behind the lens. Most often the rotation occurs in the first 1 hour after toric intraocular lens implantation. That's the reason these patients alone, we always patch the eye, see them after a couple of hours, take off the patch and send them home. Nudge the intraocular lens onto the PC so that it is sitting on it. Make a slightly smaller rexis so that there's good overlap of the rexis uniformly in 360 degrees. Ensure that the position is of the lens is maintained even once the speculum is off. And if at all there's a residual astigmatism, rotate about 2 weeks later. These are the two formula that are available to often use the Barrett RX formula. Thank you so much for your kind attention.
Thank you so much, sir, for that master class on toric IOLs. And I think the most important lesson that I learned from this talk was that calculate for all eyes, like sir mentioned, because it's sometimes in a busy OPD you tend to forget whether this is with the rule, against the rule. So don't rely on a value difference between K1 and K2. So don't have a cutoff that if K1, K2 is more than 1, you will consider. Calculate for each eyes, and like sir showed in those cases, you'll be surprised that so many of the cases where you had never thought of toric, they turn out to be T3, T4 rather than that. Yes, please go ahead.
So just one basic question. So just wanted to know, suppose if we are implanting a toric IOL and by chance or in the injector it rotates, like it front side is on the back side and back side is on the front. Is there any problem with that?
No, you should definitely, especially if it's a single piece lens with a not a plate haptic design, you need to re-rotate them back because there is a these lenses, there is a toricity on the anterior surface, some of them, and so the multifocality is on the posterior surface. It's extremely important to reverse the lenses back. But if it is a plate haptic lens, if there which are planar lenses, then there is no need for rotation of this because they are bitoric. The toricity is distributed both on the anterior and posterior aspect. So if it's a in these left leading haptic should be having the mark, but just in case you are implanted it in a reverse manner, you need not reverse that. But all the routine lenses, the single piece lenses that we use with the haptics, they need to be reversed back into the right position.
Then IQ also we have to rotate.
Absolutely. IQ you will have to, it's only the Lisa toric maybe which you can leave it like that because it's a plate haptic lens.
Also, the lenses have posterior angulation. So that lens is actually like this. If you tilt it, you might also have a refractive surprise because the lens will sit more towards the cornea.
Okay, thank you very much to the audience for staying for the course, and thank you to the faculty for being part of this course. Thank you so much.